And the operation that really we tend to go for, which is the gold standard, I would say, is what they call the laparoscopic fundoplication. You know, and then with your surgeon, for example, the discussion is whether it's a complete wrap, which means 360 degrees, or a partial wrap, which I wouldn't get too technical as far as the purpose of discussion today is, but the point is surgery in the right patient, obviously with the right preparation, can make quite a difference to experience a quality of life, and of course reduce reflux. So a little bit about the history. The operation itself was first performed in 1955, so it's been around for quite some time. It's got some different names, of course, but I think the most important thing to say is that it really became very popular in the 70s and more so in the 80s and 90s when keyhole surgery came about. And I think that's really why the Nissen, if you're looking at operations in history that have stood the test of time, this is an operation that has stood the test of time. Which is good because it's actually a procedure that is actually technically quite easy to do, but does require a level of skill and precision in order to make sure that it's done in the way that will give a good chance of success. Now, of course, it's an operation, and there are complications. There are certainly side effects which cannot be ignored. You know, when it comes to you know, a procedure, of course, but the most important thing to say that the patients that are best suited to have surgery are usually patients who probably have long-standing reflux, possibly medical therapy hasn't worked for. If the hypertonia is quite large, we do find that you can get better treatment with surgery. And certainly patients who get what we call volume reflux, so when they either stoop down or lie down, they get not just acid, but they get, you know, fluid and volume coming up because that valve has just gone, usually can benefit from an operation. So technically, what does the operation involve? Now, it's in two parts, really, if you think about it from a technical point of view. If you recall, I did mention earlier that the diaphragm had a bit of a wide opening, or it was sort of elongated. We would always narrow that. So that's the first part of the operation. The second part is just to do what we call the funder, which is the wrap. So we are wrapping the upper stomach around the esophagus and then anchoring it. And I have a few images that might help to explain what it involves. And that's really what the operation involves, two technical components. As I mentioned earlier, it's been done keyhole. The good news is that patients could either go home most times the following morning, the following day, but occasionally the same day. The pain levels are very low indeed, which I think really makes it quite acceptable. There's no need for anything strong like morphine after the surgery. Patients are able to get drinking quite quick and get up and about and pretty much back into the office, back into work within about sort of 10 days-ish, as it were. So, and I think that's why it's quite reasonably well sort of accepted, really, or welcomed, I think, when it comes to a procedure that is can revolutionize care and make patients really experience lower and reduced amounts of symptoms. So here we are. So these are the illustrations, really. And as I mentioned earlier, really, the diaphragm is the sling, which is where we put a few stitches in the diaphragm. We then use some stitches to create this wrap, which is really where we free up the upper stomach and we wrap it below and around the esophagus to create a snug. It's not tight. It's a very snug, well-positioned sort of spiral suture and anchoring around the esophagus that allows the stomach to essentially stop allowing contents to go up into the gullet. And that's still the fundamental way it works. So basically what happens is as the esophagus closes, as the stomach obviously raises its pressure, in which case bile or acid or whatever can't go back up. And that's really how it works. So those are the two components of the Nissen fundo. And of course, the other component is that it does create a slightly higher pressure area in the lower esophagus. So of course, the question is, how effective is it? And the most important thing is that it's got a very low risk of complication. And that is important. It's performed on patients who are generally otherwise well, so we don't want to get patients getting into difficulty or having a lot of uncertainty around whether they're going to have a complication after the surgery. And that's why, again, surgeons who operate on that part of the body, of course, because of all the kind of critical structures, of course, have to have a very firm and very sort of balanced eye and hand to do the work. And that's why the results remain very good when it comes to technical problems. In terms of impact on reducing reflux, a lot of the studies are saying that patients really get about 80% benefit, thereabouts, 80, maybe 70, 80%, and occasionally up to 90 when it comes to quality of life, reduced symptoms, and it is sustainable. Some studies quote 10% recurrence at about 5 to 10 years. And occasionally there's some that have to go for second surgery. So as far as I think the track record of the operation, in terms of the longevity of it, I think it still stands up very well against any of the more recent or more newer procedures which we may touch on today. So Nissen is still the gold standard operation for this, for the treatment of reflux.